Hello and welcome everyone. My name is Uma Virapan and I'm an investor on the Flare Capital team. Flare is a healthcare VC firm that invests at the intersection of healthcare and technology. We're very excited to have you join for our 22nd quarterly expert roundtable. Each quarter, we bring together leaders and innovators to explore the trends that are shaping the future of our industry. Today, we're going to be discussing our 2026 investment theses and some of the themes that we believe will define the next generation of healthcare companies. Before we get started, a quick note that we are recording today's session. You should be able to access the recording on our website, so feel free to reference after the session or share with colleagues. We hope that you find today's conversation valuable, and we look forward to continuing the dialogue with you afterwards. At a high level, our investment thesis starts with a simple observation. AI is fundamentally reshaping how healthcare enterprises buy and engage with vendors. Health systems, payers, pharma companies are actively experimenting with AI, and we expect to see continual investment. Last year, we surveyed 30 senior healthcare executives within the Flare network, many of whom belong to our strategic partner platform, which represents 25% of annual US healthcare spend. And what we learned was that over 10% of IT budgets are spent on AI solutions. These aren't theoretical conversations anymore. These are operators that are controlling massive health systems, payers, and services organizations. These groups are running pilots, testing use cases, understanding realistic opportunities to deploy AI within their complex environments. At the same time, major AI labs and automation platforms are partnering directly with enterprises on broad organization-wide deployments, and they're moving from experimentation to broader deployments. Alongside that momentum, we're seeing a second dynamic emerge, and that is a strong desire for central oversight and guardrails. Roughly 10 to 20% of health systems, for example, have established AI governance committees, and we expect that number to increase. There's increasing concern regarding agent sprawl, and AI tools can start to resemble contract labor more so than traditional software licenses. Enterprises are wary of outsourcing too many core workflows without visibility, coordination, or architectural discipline. Governance and central planning are becoming essential. And that leads to our third belief. Despite broad automation initiatives, there remain areas in healthcare that require deeply specialized, dedicated solutions. Enterprise-wide automation can be powerful, but it's very difficult to be best in class across highly complex clinical, operational, and regulatory domains. The companies that we believe will win have a few different characteristics. They operate in areas with deep clinical or regulatory complexity. They serve as critical infrastructure with meaningful switching costs. They often start within contained departmental budgets or clearly defined workflows, and they control or generate proprietary data. Our four themes today are focused on supply chain, clinical AI, payer technology, and specialty pharma. And they follow this logic. These are domains where horizontal AI platforms will struggle to fully penetrate, and where purpose-built, vertically integrated solutions can create durable value. While these aren't the only areas that we're excited about, they're four where we're seeing particularly strong signals today. We'll begin with our supply chain thesis, featuring Michael DeLuca, former SVP of Value Realization at GHX. This will be moderated by Vic Lanio. Then we'll move into clinical AI with Dr. Sharif Vakili, co-founder and CEO of UpDoc, moderated by Dan Gebremedin. Next, we'll explore payer technology with Matt Parker, Chief Product Officer at Cohere Health, a Flare portfolio company. This will be moderated by Margaret Malone. And then we'll close with specialty pharma, featuring Dr. Paul Rothman, founder and board chair of NextCure, moderated by Park Desai. So with that, I will turn it over to my partner, Vic, to welcome our first panelist. Vic, over to you.
Thanks, Uma. Hey, sorry about that. I muted myself. Before we invite Mike up to the stage, I'm going to set the table a little bit with some thoughts around supply chain. So this really fits into the broader category of back office automation in healthcare, but we're going to zoom in on supply chain and why it's especially important right now. So over the last several years, really since COVID, we've seen supply costs rise sharply. This is obviously a big factor in driving margin compression with health systems. But also AI capabilities have matured in fundamental ways that have changed what's possible. So moving into some of the macro trends that we're seeing, I mentioned over the last 5 years, this is really an incredible stat, right? It's over the since COVID, medical surgical supply costs have grown from about $40 billion to $57 billion. To put that in context, it's about twice inflation, and it's far outstripping Medicare reimbursement growth at the same time. At the same time, hospitals were already operating on extremely thin margins. So when we speak to our health system partners, we're hearing pretty consistently that they're facing explicit cost reduction mandates, upwards of $100 million of costs that they're expected to take out of their systems. So when hospital leaders look around to see where the opportunities lie, supply chain often rises to the top of their to-do list. So what makes supply chain interesting right now is a combination of how large the category is, but also how operationally manual it still is today. To put this in perspective of the hospital OpEx, right? So those top three lines on the right, supply, pharmacy, and purchase services can make up about a third of OpEx for a hospital. Over the last decade or so, or more recently in the case of AI, hospitals have put a lot of investment dollars towards driving top line, so revenue cycle opportunities, et cetera. When you go down the list, there's a lot of labor issues that come up next that have a lot of value and opportunity in them, but are politically really difficult to achieve. And so supply chain rises to the top in terms of structural improvements that can be made that are really achievable and can fix problems going forward. So many of the workflows in supply chain still depend on manual reconciliation, contract interpretation, and PDF documents, email inboxes that are exception-driven processes, human review of some of these pricing discrepancies. And naturally, what they do is they stack rank in order of priority the biggest opportunities first and have people work down those lists. Eventually, you get to diminishing returns, and it's not cost effective for a human to be working those long tail of small transactions. And that's a perfect opportunity for AI. Thinking about why this wave of technology is different. Historically, as I mentioned, these long tail issues just haven't been cost effective for traditional solutions to address. Many of the supply chain challenges aren't catastrophic failures. They're more like death by a thousand paper cuts. They're pricing discrepancies, contracts not being updated in the ERP, non-catalog purchases that slip through the cracks, backlogs that slowly accumulate. And so addressing those issues have required either having a large team of people to work down those lists, being comfortable with letting a lot of that slide, or hiring consultants to come in and do one-time cleanup projects. So what's different today is the maturity of this AI technology that we have available. These tools can read contracts, they can interpret invoices, they can reconcile automatically discrepancies that are popping up across the system, and they can work between systems in a way that is more effective than it was even a couple months ago. So for the first time, the long tail of supply chain friction is actually cost effective. So why now? We've touched on this a little bit already. First, the margin pressure with hospitals are real. The cost mandates are active, and people are taking action to try to alleviate as much of that as possible. Second, the maturity of the technology is also very real. For years, a lot of the solutions that were available were rules-based systems that didn't do very well with unstructured data, and most of the problem is in unstructured data. Third, we haven't mentioned this yet, but there's like a pretty significant platform transition happening in the ERP landscape for healthcare and in the technology layer. So there's a lot of M&A activity. There's a lot of rumors and active announcements around building healthcare specific ERPs in the case of Epic, potentially removing or divesting EHR or ERP technologies from other players. So there's a lot of tectonic shifts that are happening at the same time. And then lastly, adoption behavior in the hospital has also shifted a little bit. So health systems are increasingly willing to try these solutions. I think that seeing what's possible with revenue cycle solutions has opened up people's imaginations to what's possible elsewhere in the health system. And so we're seeing a lot of adoption happen very quickly. So when you combine that all together, I think that this is really setting the table for a profound 2026 for hospital supply chain technology. And really excited to bring Michael DeLuca to the stage to talk a little bit more specifically about what's possible and what he's seen over the last couple of years. While he's coming to the stage, I'll quickly give a little bit of background. Hey, Michael, thanks for joining us. So Michael, you have been in supply chain for 25 years. You worked at UPMC, one of our health system partners. We're on the early team at Prodigo Solutions that was acquired by GHX in 2023. Have been at GHX for a while. Want to talk with you a little bit about your history with supply chain, some of the problems that are persistent, and what might be possible going forward. But first, I kind of want to ask you, I have a 4-year-old and I'm trying to figure out what he's going to become when he grows up. And I haven't yet met a lot of folks that early on have identified supply chain as like what they want to dedicate their career to. So really curious how it piqued your imagination and set you off on this career journey.
Yeah, thanks, Vic. If I told you that I had a boyhood dream of mine was to be a supply chain management guru, I would definitely be lying. At the time I graduated from Indiana University Bloomington, the major really hadn't even yet been formally codified. So I was an operations management major, Vic. I like the execution discipline that ops management drove and at the time was drawn to the teachings, the coursework of the masters of formal operations management, Deming, Ono, Peter Drucker, and later Michael Porter. So when I graduated, I went to work. I went to work where it's warm in Arizona for Motorola and was in their semiconductor product sector. They were a vertically integrated company at the time. I was in their formal materials rotation program, 4 3-month rotations throughout the company, areas like demand planning, S&OP planning, logistics, industrial engineering, and supply chain management. And at the end, it was the varied areas of supply chain management that drew me in. It really just checked all the boxes. It bought in concepts of operations management, but I think the varied disciplines and areas within it are what drew me in. And then in 2005, a former mentor of mine, I was still in manufacturing at the time, working for Alcoa, left to take a job at University of Pittsburgh Medical Center, what is now a 24 plus billion-dollar IDN, acute care insurance services. And he invited me to come over to re-engineer the healthcare supply chain. Specifically for me, it was from the technology area and the platforms that Vic we would use to drive change in the platform. So over the next 2 decades, I learned what makes healthcare unique. Coming into it, I didn't think there was, I thought a widget was a widget, supply chain. But over the last 2 decades, I've really learned what makes healthcare unique and by trial and error how to leverage technology to drive
And
value.
maybe on that point, I think one of the kind of main topics here, and also being mindful of time, is like what are the persistent challenges that these health systems have faced over the years? So could you comment a little bit on your journey working with a health system, and then as on the vendor side with health systems even more recently, what are some of the major challenges that people are facing today?
Yeah, I think the complexities, first, I think there's got to be an understanding of the complexities that make healthcare unique and have remained fairly constant. So aspects like a blurred line between what is a direct material and what is an indirect material. In the industry, Vic, there's little to no advanced planning. Nobody's using those modules inside their ERP systems. It's an industry that's still very reliant. I'll juxtapose this against manufacturing, very reliant on group purchasing organizations for some level of sourcing and contracting, and one that is still focused on rebates. It has the complexity of a physician preference challenge. So these physicians, many of whom I got an MBA with, these folks would tell me, look, I went through residency using Zimmer Biomet or Stryker or Synthes. That's how I want to do business, especially in an acute care academic medical center. You've got to challenge the cost quality outcome model with a physician and provide evidence to get them to change. I would say also the complexities make and things that make it unique and present challenges are there are black swan events that drastically change inventory models, things like COVID, where the industry moved from just in time to government mandated required stock on items. And then, of course, you have the other intricacies, expiration date management, recalls, substitution management without a defined data source or library.
Yeah. And maybe shifting gears a little bit into what you're excited about, and maybe this is a combination question. It's what are you surprised hasn't seen more progress in the supply chain space, technically speaking? And what do you think might be different going forward? What are you most excited about now?
Yeah, I think what excites me now is when I look at the industry, it is the ability to leverage Vic Gen AI, not just for analytics or to make jobs more efficient, but really to combat the challenges that I talked about earlier operationally. For example, a little more context for the viewers here. There are approximately 40 million SKUs in healthcare for healthcare providers to manage, and there are approximately 750,000 contract conditions changing daily. So contract utilization becomes key. Most consultancies are basically will still report that greater than 60% of identified savings and negotiated contract savings are never realized. So it's leveraging Gen AI not just on the front end in the demand shaping aspect of healthcare supply chain, but also that low hanging fruit that exists on the back end. So I'll give the viewers some examples. Things like building shopping carts for users that dynamically change, where requesters are not even going into a procurement application. A cart is being built based on order history and being ordered and tweaked by the user. To dynamic messaging and correction at the time of order. Rather than analytics and reports, make a substitute change operationally. Identify that there's a recall and mitigate that item in the cart, or apply contract governance operationally. So rather than these being analytics that then require a person to take action, leveraging it to correct the match exception, inform relevant parties, make updates to system of records, initiate rebate requests, things like that.
Yeah. And I know where this time has already flown by, and I don't know if you have any closing thoughts, but I do hope that maybe this conversation did spark some, I don't know if there are any children out there watching this, but interest in supply chain for 2026. It's obviously a very important area of improvement and a good opportunity for AI as any, I think. But I really appreciate your time, Michael, and I know this is just the beginning of the conversation. So with that, we'll transition over to my partner, Dan, for the next topic.
Yeah, good to be with you, Vic.
All right. Thanks so much.
Thanks, Vic. Great conversation. I'm Dan Gibbermedden, one of the partners at Flair. I also spent over a decade as an internal medicine physician at the Mass General Hospital. And before we introduce our next speaker, I'm excited to share how we're starting to think about the clinical AI market space. At Flair, we've unofficially termed 2026 as the year of clinical AI. And while there are several use cases for clinical AI, we'll be focused on primary care use cases today. While pundits have been foretelling the coming of AI doctors for years, we're now seeing the building blocks of real adoption falling into place. With the advent of transformer and LLM technology, we are seeing both consumers and clinicians adopting AI into their daily life and workflows at extremely high rates. Instead of simply retrieving and providing information, agentic technology enables the completion of tasks that can generate revenue for clinicians and save valuable time for consumers. We're also seeing regulatory barriers to adopting AI into clinical practice begin to lift. The CMS access model is structured in such a way that incentivizes the use of clinical AI tools. And ARPA-H has launched several clinical AI initiatives to drive adoption into practice. We're seeing policymakers shift to a deregulation with safeguards approach for compliant builders. And finally, while there are a lot of applications for clinical AI, we see the $40 billion virtual care market as particularly ripe for disruption. We've estimated the clinical AI market today is roughly $2 to $3 billion, but growing to 5 times that amount over the next decade. All of these trends have informed our investment theses in looking for clinical AI investment opportunities. We're looking for solutions that not only provide insights, but are able to act on these insights to execute actions that drive quantifiable value for enterprises. These solutions must price their platforms relative to the value being created, and will have to avoid legacy SaaS per-seat pricing models. As competition heats up in the space and core technology becomes commodity, solutions will need to track longitudinal data and measure outcomes on value creation. They will need to be accurate and clinically valid, while also being auditable to generate trust. If they do this and complete these must-haves, we think these companies will have a right to win in a crowded marketplace. Finally, if early-stage companies achieve these milestones, there will be a number of potential acquirers. These acquirers will look to consolidate these tools into existing technology platforms, or to use these tools to drive down the cost of care, to improve care margins in their existing delivery businesses. With that, I'm excited to introduce our next speaker. Sharif Vakili is the unique combo of physician, former investor, and now scaling founder, innovating on the front lines of clinical AI with his company, UpDoc. Sharif, thrilled to have you here. For our audience, tell us a little more about yourself and how you got to UpDoc and what is UpDoc doing in the market.
Yeah, thanks, Dan. My own background, I'm a primary care physician, by training. Also went to business school and got involved in building startups and was an investor formerly at Polaris Partners. I know we worked together there a good bunch. And I practiced on faculty at Stanford. Actually, a lot of this work started in the academic realm before the company was created. And when we started this effort in the academic realm 6 years ago now, we talked about clinical AI. People thought we had three heads. Like it didn't compute. This was before the days of ChatGPT and generative AI being a big thing. Now the world is converging on this technology, and there's more convergence to come. It's still a nascent field because it takes a long time to build this correctly and effectively.
No, it's helpful. And you've clearly been working on this for some time, but now clinical AI is entering the mainstream. How do you define clinical AI, and what does good clinical AI look like?
Yeah, so the way we define clinical AI is any kind of AI agent delivery, right? These AI agents that are powered by constellation of models that are post-trained, they have their own unique technical architecture that power what you experience as an agent, right? Either through text or audio or visual also. And that agent is delivering care that would historically be done by a licensed provider. So clinical AI is that. It's when the AI agent is doing something that is higher risk that formerly may have been done by a physician assistant, nurse practitioner, pharmacist, etc.
And maybe translate to what is UpDoc doing in the market?
So UpDoc has we've been in stealth mostly for the last several years since our founding. We have a very particular approach to clinical AI. We have been tackling this in a way that is workflow integrated, where the clinical AI is a cook in the kitchen. Saying, in other words, it's integrated in the EHR. It'll drop a note like a human would drop a note when does an intervention. It'll update the med list like a human would update the med list. And it's a particular modality that when we did this kind of modality for the first time in an RCT, the couple got published in JAMA, we called this modality remote patient intervention in comparison to remote patient monitoring. So we'll be talking a little bit more about our technical architecture and like the differences between, because the way that people have historically been thinking about clinical AI, just as an intuitive sense, is like Dr. ChatGPT, which is an important area of medicine, and that will be really good for acute care kind of management, right? If you're going to be doing chronic disease management, you want something that's a little bit more workflow integrated, isn't necessarily direct to consumer. And our approach to that very high level is the best analogy I can give is when Waymo uses LiDAR scanners to map a city and then collects data back and tests and meticulously increases autonomy with its own technical architecture. And in our case, the cities are diseases. And we'll have more on this, but good clinical AI is one that does that very carefully, very thoughtfully, does it in a way that recognizes not just the clinical realities the patient has to go through, but the operational realities. Because many times, actually, what we're doing in primary care is coordination. The diagnosis isn't necessarily the hard part. And then, as you alluded to earlier, it's got to be auditable. You have to be able to recognize, both as the physician, what the heck's going on to your patient, but then as a system, what's happening to all your patients and patient-physician interactions from a safety and governance standpoint.
And I love the analogy that we can all right now see on the streets of self-driving cars, that the error rate has to be exceedingly low, and you need to have context in order to make real-time decisions. Maybe transition a bit to just commercialization of clinical AI technology and where we are in the market. What are established enterprises buying? Do they know what they want? Do they know what they want to buy? And then maybe as an extension of that, Uma talked a little bit about this new phenomenon of AI governance committees and what role do they play when trying to sell into enterprises?
Yeah, great question. So right now, most systems do not know what they would like to buy and they wouldn't, right? These products haven't really matured in the market, and they're doing really radically new things. There's a good bit of education that goes into understanding this until it reaches the zeitgeist, and then everyone starts to understand how these tools actually function and can become intuitive. And the other piece of this that's a barrier is the payment structures that exist create some trickiness around commercialization, because 9 out of 10 physicians operate on a fee-for-service chassis in the United States, right? So if you have clinical AI in the 1 out of 10 that's in a purely capitated environment like VA or Kaiser Permanente or Oak Street, clinical AI makes a lot of economic sense. You're a PCP in an environment where you have a panel, you don't bill, you don't care about the volume that's coming through the door. And this clinical AI is going to make your life way better and be able to handle some of that work, and the economics are aligned. Now, going to a fee-for-service setting, whether in an ACO or shared savings program, when you prescribe this thing or you work with this thing, it's taking away your business. You might as well give your business to a competitor, right? It's taking away that fee-for-service revenue, even if you have pop health metrics or other things that come up. And so there's always going to be tension there. So some of the commercialization, or the health system that's been built in fee-for-service, it's always had its perverse incentives, is rearing its head again here, where some of the ways in which the health system has been set up needs to be updated. And that will come as data comes in and evidence is proven out and these things mature in adoption.
Yeah, and I think you started to allude this concept of the care output. You recently published an article in the New England Journal of Medicine around reimbursement for AI and clinical AI technologies. Maybe expand upon that. What did you learn in your research for that piece? Like, what were some of your ultimate conclusions on how large established enterprises can adopt clinical AI and then drive reimbursement for it?
Yeah, this is a piece that was published 2 weeks ago in the New England Journal of Medicine that we had in the Catalyst magazine. What we propose, and we've been working on this for a while, so we have some insights around this, but we do genuinely invite others to join the conversation here, is that when you recognize tools that improve productivity and reduce physician time struggle to get adoption with the code set that is mostly paying for physician time, but work hard use physician time, right? So I'll give a very specific example. If you were to have a visit with your doctor, and that visit was over telemedicine video or in person, that doctor will bill for that visit based on either the time they spend with you or something called MDM, medical decision making, the complexity of care they deliver. They'll be level 2 through 5 and get billed $50 to $150 for that visit. What that means is if that doctor were to use an AI tool, let's say like a scribe, to make themselves more productive, they wouldn't be shooting themselves in the foot and get paid less because they can build MDM for the output of what they've delivered. Now make that visit take place over text. Have it be asynchronous. The only mechanism to be paid is for time. So if you use an AI tool to make yourself more productive, you're going to get yourself paid less. It just doesn't make sense. And so what the paper kind of illustratively discusses is like, we should add MDM to digital EM, the asynchronous EM, to be able to encourage adoption of those tools. And by the way, digital EM pays 1/3 the amount of EM and is only used in 0.1% of cases versus 40 to 45% of EM. There's a huge opportunity to shift care towards lower cost care if we do this in a thoughtful manner that engages the physician.
That's great. And I think clearly there's a need, right? There are clinician shortages, long wait times. There are great technologies that we can use. Health systems and large enterprises are still trying to figure out how they're going to use it, but then they also have to figure out how it's going to drive their own business model and how you resolve some of that channel conflict as we move away from a fee-for-service system. So a lot of great insights, Sharif. Again, I wish we had more time. I know we'll continue the conversation. We really appreciate all of your insights today, but I will have to turn it over to my colleague, Margaret, to introduce our next topic on Payer Tech. Thank you, Sharif.
My pleasure.
Thanks, Dan. And thanks, Sharif, for joining us. I'm very excited to be here. Before I welcome our guest, Matt Parker, the Chief Product Officer at Cohere, I want to frame the high-stakes environment that payers are currently navigating. So at Flare, we're seeing a payer operating model under acute strain. Between the 50 billion surge in pharmacy spend, largely driven by GLPs, and the 17 billion in annual claim leakage, the margin for error has essentially disappeared. The industry is desperate for efficiency, but there's a massive trust gap. Our latest Flare Capital survey shows that 97% of health plan executives feel that AI is not yet delivering proven value. Most describe their current state as pilot purgatory, and even more challenging, 40% of those health plan executives say that AI deployed by providers is actually increasing cost and friction for them. So it's an arms race, and right now the payer is behind. But budgets are moving. So in January, we surveyed both the national and regional health plan executives, and the takeaway was clear. Payers want the outcome, but they're not getting it at scale, at least today. And the universal focus is still medical cost containment. In our view, payers are signaling pretty clearly that they're not looking to buy 5 or more point solutions. They're looking for solutions that are impacting operational friction, actually removing some of that operational friction, and are able to offer safe, scalable deployments embedded in their core workflows. And thus, a key learning is that integration component is critical and can be a moat for early stage companies. Member experience is increasingly table stakes, especially for the national plans, and smaller and regional plans are still structurally behind. They are actively trying to catch up on their outdated data and infrastructure to remain viable. As such, we're finally seeing a legacy vendor swap. About 48% of the payers we surveyed are actively decreasing spend on legacy vendors and shifting those dollars to emerging tech. Our thesis is that ROI in 2026 won't just come from an all-in-one platform replacement. It'll come from the layers that are sliding into existing workflows, proving ROI quickly, some as early as 90 days, and then expanding from there. While we're evaluating a handful of near-term opportunities across the payer landscape, the bullseye for this is and prior authorization, which brings me to Matt Parker and Cohere. We are investors in Cohere, and I'd say Cohere is the rare case study of solutions in the 3% who are demonstrating significant proven ROI for payers. They've solved how to make agentic automation touch production decisions safely while reducing provider friction instead of just adding to it. Today, Cohere works with over 660,000 providers and handles more than 12 million prior authorization requests annually. Prior to joining Cohere, Matt was the SVP of product development at Kairos, led product at HealthSpark, and has been really in the front row seat in this arms race. So Matt, thank you so much for joining us. We're very excited to have you. I want to start our conversation with this kind of value gap question. As I described, our data shows that legacy vendor swap is underway. Payers are feeling the threat from provider AI uptake. Curious to hear from you. Are you seeing payers turning off some of their old legacy systems? And maybe just comment on the burning platform that exists today.
Yeah, I think I agree with your framing earlier about it really being a sort of a disinvestment in legacy systems. I think the switching off hasn't happened yet. I think the switching will come after the results of the sort of the new investments. So that tends to be, there are probably exceptions to that, but in general, I think it's more of a yes and than a cold swap out. They're too risk averse, I think, to close down things that work until they have proven solutions. But actually, it gets into sort of the why now component of it. I think you commented on costs. I think cost increases are a big part of it. I think we see a couple of areas in addition to what you identified. The AI arms race, I think providers are getting way more sophisticated in finding ways to charge the maximal amount for any particular patient engagement. And so you see that cost. There is higher admin costs in general. So a good driver for AI efficiency gains. And of course, the reimbursement rates for the MA plans was going down, which is driving a ton. So you see big levers around stars and MedX and operational efficiency that are driving a lot of the motivation for some of this investment. I think the other thing is the pace of technology innovation. Frankly, there are just things possible now that weren't possible a year ago or even 2 years ago. And so I think what you're seeing is the ability to solve problems is getting better at rates that we haven't seen in normal healthcare investing, which I think is forcing payers to move faster than they normally would have historically. And coupled with that is you see a talent shift, right? So a lot of senior leaders at payers are moving on, retiring, et cetera, and being replaced with folks that are coming in from consulting groups or other technology organizations that are more familiar with the AI digital transformation space. That's helping a lot. I've been selling to health plans for 20 years, and the turnaround and the new type of leaders driving for speed of change is very new in the payer space from my experience. And the last, I don't prior auth in UN is such a it's almost a third rail. I spend way too much time on Instagram and TikTok on the weekends looking for videos of people with horror stories about my care was denied, providers recording their calls with health plan reviewers and talking about why they're getting prior auth denials. Like it is the last year and a half has been a relentless cell phone around prior auth by a lot of payers. And that drives the payers have shifted focus. They're really thinking about trying to rebrand themselves as healthcare organizations and not payers. That's very intentional activity. And we see that sort of like shifting away from the idea of find and recover to prevent and align, which gets, we'll probably talk a little bit more about provider experience, but I think that's a big part of why you're seeing these investments in new and novel technologies that are trying to drive towards these outcomes.
Yeah, that's great. I think we talked a little bit in our prep session, but that was a clear signal coming out of our survey, which is that
Yep.
focus around member engagement and reducing some of that abrasion. I am curious. So let's talk a little bit about the wedge, because we touched on it when you briefly mentioned UMMPA. We hear from a lot of founders just trying to navigate offering a broad solution versus maybe what you would describe as a point solution. And Cohere has obviously been very successful in navigating this. Can you just, I think, help the audience understand how you think about what the right workflow to start in, what's open versus maybe how to navigate just knowing that there are legacy vendors managing some of those workflows today?
Yeah, I think a platform sale is really hard with a payer because you run up against two sort of major headwinds. The first is the cost, the sort of the replacement cost is daunting. Project management within a payer space is rough, and you're going to going in with a significant platform redesign or rebuild has huge investment project. It's hard to get budget for that kind of work. Going in to solve a specific problem with a clear ROI de-risks a lot of that for payers, which I think is helpful. The other reality is within these payer organizations, very similar use cases are delivered by very different teams, right? So part of the Cohere model, prior auth in UN is really about, it's a very discrete problem. It has a nice space, but it does foundationally have a similar touch to appeals, to care management, to stars, HEDIS, and quality. There's a whole series of elements that all have similar activities that happen on the payer side in the back end that are all managed by very different teams. So you get into one, then you can start expand your use cases to cover those other areas. I don't want to say it's a backdoor platform strategy, but it does allows for you to go improve value, especially when they're taking a gamble on a new solution, show the impact of that, and then proof of concept your way into a broader scope, which is, I think, tends to be how we've tried to do a land and expand.
Yeah, let's talk a little bit more about land and expand, because obviously that's where we're seeing so many companies struggle in the pilot purgatory that they're in. What have you learned? Is there integration hurdles you all have had to overcome, or specific ROI or product capabilities or thresholds, just as it relates to being able to effectively expand once you're in?
Yeah, I think AI, so there's a lot of answers to that. I'll focus on the AI side. I think AI is about trust. Fundamentally, it's scary for payers. They're incredibly conservative. These are organizations that are built around the idea of reducing and spreading risk. Like they're not really focused on testing and trying and failing fast. That's not in their DNA. So establishing the guardrails and trust and experience around AI is a big part of that. For us, we focus on human in the loop as a way to do that. So our initial use cases really are baked on a couple of things. We have a significant amount of clinical investment. We have 30 or 40 MDs on staff. We have hundreds of nurses and other clinicians and informaticians, and they're all working on our ground truth data over our volume of activity, which really helps prove it out. We also focus on delivering a lot of the AI capabilities to use cases, starting with things where there's direct human engagement. So we're not asking people to jump headfirst into fully agentic, completely removing people from the equation. So starting with things like co-pilot applications that are sitting alongside clinical decision makers and assisting them be more efficient, higher quality. becomes really measurable and observable. And so building that trust along the way is a way you get out of that, because then you have very clear ROI stories. We do spend a lot of time on our kind of initial touch points with payers around the business case. So there's a very clear financial story on what we're doing and delivering. And we calibrate across the kind of first part of our client life cycle after we've gone live with anything, is really about calibrating to those expectations. Once you've proven that out, you've built the credibility and trust to go into that next growth area.
Yeah, that's so critical. And I know we could probably talk a lot more about that special topic, but I do want to end on this question of the arms race. We talked about it for a second and the intro, but I think Cohere has taken a very collaborative approach to UM. Curious, like, how do you think about product as it relates to the bot to bot dynamic, and how have you approached just creating that sense of trust, truth with both sides?
I feel somewhat blessed that is a place where the bot to bot battle is actually not that big of a deal. And the reason why I say that is the payers are trying to avoid waste in the system. And with clinical policies and guidelines driving the decision making, there's usually fairly clear indicators on when something is going to be approved or denied. And actually, the bot to bot battle is about getting the higher quality submission in the first place. So the more providers can properly submit a case with the appropriate clinical documentation and all the relevant information, you actually get to a faster approval, which benefits sort of both sides of the house. Where you start to see areas of challenge is more on the appeal side. So we're starting to see, for example, cases that are properly denied, where you've got bots that are going out and scouring what are the overturned things on that the third-party auditors follow up, and refining and overloading the system with appeals activity, which then degrades the process. You get a fast decision out of the front, it's clinically justified, then you have to come back in and go through an appeal process, which is incredibly expensive. It's the most compliance-laden part of the process. Payments are the other area, right, where the bot to bot battle is going. So maximizing your DRG billing is a common activity. And it's a lot easier for a provider system to focus on how do we find the little snippets of evidence in the clinical record that allow us to build this up at a higher rate. And that's where you see the arms race escalating over time. I think the U space itself is the place where I do think we have the best alignment on continuing to focus on that provider collaboration, because if we can get those initial decisions clearly documented, clearly understood, and collaborated in a simple and easy way, we're doing all the work we're doing on the interoperability, for example. We have a not insignificant number of auths come in. The provider doesn't even know it was submitted. It was submitted automatically by the EHR, evaluated and responded to without the provider ever getting involved.
Yeah. And Matt, I hate to cut this conversation short because I think we could keep going.
No, sorry,
the collaborative piece is huge. No, thank you so much for your time today. I need to pull up Parth to the stage to let us wrap up with our specialty pharma. But thank you so much, Matt, and excited to spend more time together.
Thanks.
Awesome. Thanks, Margaret and Matt. And on the anchor leg here, I'm excited to share a bit more with you all about our pharma thesis for 2026. Next slide. As we all know, the legacy pharma model today is facing pressure. Roughly $400 billion of revenue is at risk through 2020 through 2030, result of patent cliffs and price negotiations. And so pharma needs new revenue streams. It's coming from specialty drugs, which make up about 60% of pharma's 5-year pipeline value. I am back. This has happened, unfortunately, 2 ERTs in a row, so we're gonna have to fix this, but here we are. So I think I wrapped at a point that we're trying to make, which is that AI and scientific R&D is only expected to grow specialty volumes moving into the future. But the challenge we're facing today is market access. Specialty drugs still run on retrofit legacy rails, and those rails just weren't designed for the complexity of these drugs. These drugs are high cost, they're high touch, so administration's governed by totally different rules. And this creates tension in the economics. Specialty drugs just don't meet traditional cost effectiveness thresholds, and cost and coverage vary wildly by site of care. And so our view is that until we modernize the administrative services layer, we can't fix a lot of these problems. So what's the opportunity today? So today, providers, it's about improving outcomes, right? By speeding up time to therapy. It's a process that's slowed down by the difficulty of navigating complex rules that govern networks and authorization. For patients, it's having data to provide coverage transparency. Out-of-pocket costs can spike quickly, fuels abandonment. And for payers, a specialty is a disproportionate share spent, so formularies are tight. And while payers want outcome-linked payment models, the workflow and measurement infrastructure to execute that at scale just isn't in place today. The way we view it is that AI is the unlock, particularly large language models. They finally make it possible to rebuild these workflows end to end. So for the first time, modern AI systems can handle the messy reality of specialty workflows, unstructured documents, multi-step processes, coordination across many stakeholders, and that unlocks agentic automation. Agents can reason from messy data to automate benefit verification and financial assistance. AI can also enable site of care expansion into ambulatory and home settings by making scheduling and monitoring scalable outside of the hospital. And AI also has an important role to play in modernizing cold chain logistics by combining real-time tracking with clinical risk prediction. This could mitigate the $30 billion of waste that occurs each year just when a biologic doesn't conform to strict stability requirements. And all of that could potentially allow payers to start to align outcomes to utilization management. And with that, I'd love to bring in a clinical and operating leader who's building right at the intersection of all these trends, Dr. Paul Rothman. Paul previously served as the Dean of Johns Hopkins University School of Medicine and the CEO of Johns Hopkins, where he led the institution for over a decade. Paul serves on the board of LabCorp and Merck today, and he's the founder and board chair of NextCure, which is tackling a core bottleneck in advanced therapeutics, which is scaling access to biologic and CAR T therapies. Paul, thanks for joining us, and we'll jump into some quick rapid fire questions here. First one is, from your perspective leading Hopkins and now building NextCure, what's changed in the last few years that makes transforming specialty therapy delivery both necessary but actually achievable?
Thanks for having me today, Paul. For me, it's really driven by science. Not only do I run Hopkins, but I'm a physician scientist and been doing science for over 50 years. And I think it was predictable at some level after the Genome Project that we were going to be able to tackle what previously were untackable and untreatable diseases. And we're seeing that today. You add CRISPR and what we now understand about how the immune system keeps cancer in check. The science has driven the development of these specialty drugs that you talked about. And as a physician scientist, it is just incumbent for medicine to figure out how to get these drugs to people. And I think that's what's driving what NextCure and other companies to figure out how to get these out to patients that really need them.
And Paul, what is the biggest bottleneck that you think hospitals face today in scaling these programs? There's just such a small fraction of them today that administer CAR T therapy.
Yeah, right now most CAR Ts are only in the academics. That's 5% of hospital beds are in those programs. And there's I sort of put bottlenecks into two classifications, one of which I'm going to say is just capacity, and that has to do with beds. A CAR T cell patient could take up to 2 weeks in the hospital. It is expertise. When we first began checkpoint inhibitors, they were only in academic centers because they were complex, but they were very quickly moved out to the community because we understood why some of the checkpoint inhibitors caused the issues, and we could treat that. Our T cells are actually much more complex than the IO drugs were. And the expertise is just not out there in the communities because they are difficult drugs to give. And so I think that's the other sort of limiting we have. And then the final one, and you touch on that in your discussion, is the payers. And just figuring out how to get payers to pay for these drugs. And when we looked and started NextCure, that ends up being an issue, but not the issue. The issue is the inability of the delivery systems to just figure out how to get these drugs to patients.
Yeah, and it's a good tee up, right? We talked a little bit a moment ago about our thesis areas on where technology and AI in particular can create efficiency in these workflows, but NextCure is using the technology for things like patient selection and remote monitoring. Where do you see maybe the highest leverage opportunity in the near term for AI to streamline NextCure's ability to help these systems deliver these therapies?
Yeah, that's a good question. There are two areas that we're using AI that we think it's going to be really helpful. As you said, one is patient selection. So presently, most CAR Ts are given for hematologic malignancies. Probably 30 to 40% of patients could get those as outpatients if you select them right, because if not, these people get sick as outpatients. So I think patient selection is really key. And then monitoring, because presently 20 to 25% of patients who get outpatient CAR T cells will need rehospitalization. The opportunity is going to be as the CAR T cells move from the hematologic malignancy space to the autoimmune space. The ability to select patients will be really important because you're going to have a lot more patients getting these, and they're going to be less sick than the hematologic malignancy folks. And so we think that most patients with autoimmunity will be able to get CAR T cells as outpatients, but we're going to have to figure out which ones can and cannot. The other area that you mentioned was monitoring. So because these patients, some do get sick, remote monitoring and the ability to set up AI to early identify folks who will need to come back to the hospital, I think is key to our success.
Paul, I want to go back to one point you mentioned, which I thought was an important point because it's at the crux of coverage and access is payer coverage. Are there a couple of signals or endpoints that, for example, NextCure is prioritizing that you think will accelerate payer coverage of these therapies, data, protocols, specific clinical outcomes?
I think the payers really like NextCure because right now, most places are only giving CAR Ts as an inpatient. The cost to a payer there is $1 to $2 million. The cost and as an outpatient is about $500K. So payers really like NextCure. That being said, they want to make sure that we can deliver these therapies safe to the right patients. But we have found payers, when we tell them our story and start to think about working with them to give CAR T cells, they're all in for us. So they think they're going to bring down their costs for these drugs pretty quickly.
Is there a single metric, Paul, that you think you'd point to that proves that the NextCure model is working? So time to therapy, capacity, outcomes, cost reduction.
Yes, I think we have to show all those things. Right? But right now, patients are waiting 4 weeks once they get approved by the insurer to get them because of the lack of capacity in academic centers. So for us, that's key. We got to get these therapies out to patients. These patients are sick. They need them. And for us, we're very mission driven here. We're getting these therapies out to those who really need them. That's what drives NextCure.
Last question for you, Paul. What was hard to operationalize 5 to 10 years ago when you were at Johns Hopkins that you think is actually now finally feasible today?
Boy, you've had a lot of great speakers here, and listening to all those, and we try to move technology. I think technology has to make our delivery system more efficient and cheaper. And so whether it be the clinical AI, it's funny, Sharif was one of my med students. I remember giving him his degree at graduation. So you talk about clinical AI, you talk about supply chain and just protocols to ensure the safety for patients. All those things are feasible today. When I began at Hopkins, they were not. So I think it's really great.
Excellent. I know we're coming right up on time here. Sorry we were cut short, but Paul, it was a pleasure to have you. And I want to thank you and all of our panelists for the time here today. Our next ERT is Tuesday, June 9th, 2026. Please keep that on your calendars and don't hesitate to reach out to any of us if you have questions on any of the 4 topics we covered today. Thank you.